Welcome dear students. While learning about the intracranial complications of otitis media, in this video let us look into otogenic brain abscess, meaning the brain abscess that is caused because of ear infection. What is a brain abscess? It is a focal suppurative process of the brain parenchyma. Now, a brain abscess could be either a cerebral abscess or a cerebellar abscess. But please note that the incidence of cerebral abscess is more than cerebellar abscess. More common than cerebellar. Among cerebral abscesses also, temporal lobe abscess is more common. So, in brain abscess, there is a circumscribed collection of inflammatory exudates, and this is surrounded by an area of inflammation. First, there is collection of inflammatory exudate. And this is surrounded by an area of inflammation in the brain called as encephalitis. That area is encephalitis. This can happen either in the temporal lobe or in the cerebellum also. Now, most of the cerebellar abscesses are because of suppurative otitis media. Now, it's very interesting to note that out of all the brain abscesses, 50% of them are caused because of middle ear infections. In children, 25% are because of middle ear infection. 50% is in adults and 25% is in children. Out of all the brain abscesses, half of them in adults are because of ear infection. So, this highlights the importance of middle ear infection and treating them as and when required. Repeat. It takes a period of 1 to 2 weeks for the middle ear infection to develop into an otogenic brain abscess. So, that is the time that we get to treat the condition. And what is the incidence of this condition? It is seen in children in the pediatric age group as well as in the 4th decade of life. So, it has a bimodal age distribution. Whenever there is bimodal age distribution, we generally think it is infancy and extremely old age. But here please remember, pediatric age group, of course you will remember, and the other one is 4th decade of life. Remember. And if you look at the male and female preponderance, there is male preponderance. The ratio is about 3:1, more commonly seen in males. And among cerebellar abscess versus cerebral abscess, I told you cerebral abscess is more common, but cerebellar abscess is more fatal. The mortality is greater with cerebellar abscess. So, these were certain general features that you needed to know about otogenic brain abscess. Now, let us proceed to the pathology. As you know, this is an infective process. So, the infective organism will first produce local pachymeningitis, and then it proceeds to cause thrombophlebitis. And this thrombophlebitis will penetrate the cerebral cortex of the temporal lobe usually, or sometimes the cerebellum, and lead to abscess. And sometimes the infection may extend along the periarteriolar Virchow-Robin space, and from that space it goes into the cerebral white matter. This is another route. If it is a cerebellar abscess, it's preceded by lateral sinus thrombophlebitis generally. And if it is a cerebellar abscess, it usually is within the lateral lobe of the cerebellum. Cerebellar abscess, you must remember a few points. You already know that this is less common to cerebral abscess. It is more fatal. The mortality is higher. And it is usually preceded by lateral sinus thrombophlebitis. And it usually involves the lateral lobe. Of cerebellum. So, these are the various broad points, and the formation of abscess occurs in stages. There are 4 stages that take place. The first stage is called as the stage of invasion. What happens in the stage of invasion? There is initial encephalitis, inflammation of the brain parenchyma. But in this phase, the symptoms, the clinical features are very mild. The patient has some low-grade fever, malaise, drowsiness and headache. They are usually ignored. We cannot anticipate it is going into something as bad as a brain abscess. It's usually ignored. It goes unnoticed. And this happens for a period of 1 to 3 days. What exactly is happening during this period? The microorganism, the infective organism is migrating along the perivascular sheath of pial vessels. The organism is migrating along the perivascular sheath of pial vessels. And from there, it goes into the substance of the brain and it causes focal necrosis and liquefaction. Around this area of focal necrosis and liquefaction, there is a zone of intense edema. There is a zone of focal necrosis. And the second stage is the stage of localization. What's happening in this phase? This is a latent stage. Here also there are no classic signs and symptoms. It's more or less an asymptomatic stage. The main event that happens here is the pus that is formed gets localized in one area because there is formation of capsule. Once there is capsule formation, it gets limited to one area. There is a localization of the pus. This goes on for about 4 to 10 days. And this capsule that is formed, it consists of inflammatory tissue and fibrous material. This is the second stage. Now the third stage is called as stage of enlargement. It is during this stage that the abscess gets manifested. Manifest abscess. So now there are signs and symptoms. The abscess will begin to enlarge and it takes about 10 to 13 days. This period lasts for about 10 to 13 days. And this enlarging abscess is now surrounded by a zone of edema and this aggravates the severity of the clinical manifestations. Why do clinical manifestations start occurring now at this stage? One is, as the abscess grows, there is raised intracranial tension. And second is, a particular area of the brain is involved, leading to focal features. So these two are responsible for all the clinical signs and symptoms. So what you have to remember here is, the abscess enlarges in size, it grows. And now there are clinical signs and symptoms. Next comes the fourth and the final stage, which is called as stage of termination. During stage of termination, there is a rupture of the abscess. And this is the last stage. It is the final stage of 14 days. If it is a temporal lobe abscess, it ruptures into the lateral ventricle or onto the surface of the brain. Surface of the brain means in the subarachnoid space, and that will develop into fatal meningitis. If it is a cerebellar abscess, that ruptures into the fourth ventricle, and when it ruptures into the fourth ventricle, it can cause herniation of foramen magnum. This is the final stage. Temporal lobe abscess ruptures into lateral ventricle or into the subarachnoid space. If it is a cerebellar abscess, it ruptures into fourth ventricle. So these are the four stages in the pathology of abscess formation. First is the stage of invasion, followed by stage of localization, enlargement, and finally rupture. Now before this, you must know the route of spread of infection. What are the various routes? Now that depends on whether it is a cerebral abscess or a cerebellar abscess. If it is cerebral, it is usually a direct extension of the middle ear infection through the tegmen or by retrograde thrombophlebitis. If it is an extradural abscess, the tegmen is eroded, but here it mostly occurs by venous thrombophlebitis. If it is a cerebellar abscess, then what is the route of spread? It usually occurs as a direct extension through the Trotman's triangle or by retrograde thrombophlebitis. This is also associated with extradural abscess very commonly, or sigmoid sinus thrombophlebitis, or labyrinthitis, or perisinus abscess. Here retrograde thrombophlebitis is uncommon. Cerebral abscess is mostly because of retrograde thrombophlebitis, and cerebellar abscess is usually by direct extension. So you have understood the routes, I hope, and now let us look into the causative organisms. Both aerobic as well as anaerobic bacteria are involved in the causation of brain abscess. Multiple organisms are seen. Polymicrobial cultures are observed, and they depend upon the immune status of the host. Let us see what are the common organisms. Under aerobic, we have pyogenic staphylococcus, Staph aureus, the most notorious bacteria, Streptococcus, Streptococcus pneumonia, Streptococcus hemolyticus, both of them. These are gram-positive organisms. Coming to gram-negative, Proteus mirabilis, Escherichia coli, Klebsiella, and Pseudomonas aeruginosa. If you look at anaerobic organisms, the most common ones are Peptostreptococcus and Bacteroides fragilis. Now the reason why you have to remember all these is, this knowledge will help you in prescribing the relevant antibiotic, because you know that both aerobic as well as anaerobic organisms are involved in the causation. You will include an antibiotic that covers both. So after the causative organisms, now let us look into the clinical features of otogenic brain abscess. Number one, there are general features such as the patient appears toxic, drowsy, and complains of a deep headache. Okay, there is deep headache. drowsiness, dizziness, ataxia, vomiting. When will you see all of these? If there is a cerebellar involvement. If it's a temporal lobe abscess, seizures are usually seen. Now, the clinical picture of brain abscess is associated with that of extradural abscess, meningitis, thrombosis and labyrinthitis, because commonly in all of them, there is focal involvement of the brain as well as there is meningeal irritation. So, the clinical picture will kind of overlap and sometimes you cannot exactly point out what it is. But there are certain features that specifically point out to the area of brain involved. So, let us look into them depending upon the area. Localizing features can be seen. And there is something called as nominal aphasia. If the lesion occurs in the dominant cerebral hemisphere, that is, in a right-handed person it is the left hemisphere and in a left-handed person it is the right cerebral hemisphere. If a lesion occurs in them, the patient will suffer from nominal aphasia. What is nominal aphasia? The patient knows everything about it but cannot name the object. Suppose the patient will point out to this and say this is used to indicate time, this is worn on the wrist and everything, but he cannot say that this is a watch. He can say that this is used for writing, this is used for noting down points, it is written on a paper and everything, but cannot say this is a pen. This is nominal aphasia. They can usually describe the utility of the object, but they cannot name the object. That means they know what it is, but they are not able to tell the name. That is why it is called nominal aphasia. And when does this occur? Lesion in dominant cerebral hemisphere. Second, contralateral homonymous hemianopia. All these hemianopias are learnt in ophthalmology, right? Neuro-ophthalm. Why this occurs here is when there is pressure on the optic radiations, this is seen. Pressure on optic radiations. The visual field defect is observed usually in the upper quadrant and sometimes in the lower quadrant also, and that is opposite to the side of the lesion. That's why it's called contralateral homonymous hemianopia. And how do we assess the visual field? By doing perimetry or by something called as confrontation test, which is done by the examiner. The visual field of the patient and the visual field of the examiner are compared, and that's how we elicit the range of the visual field. Perimetry is a more objective test. And then contralateral motor paralysis can occur. On the opposite side, there is weakness of limbs. If the abscess is spreading upwards, which usually it does, there is facial palsy first, and that is followed by palsy of the upper limb, followed by palsy of the lower limb. This is the usual progression when the abscess is going in the upward direction. Abscess in upward direction, palsy is in downward direction. Facial followed by upper limb, followed by lower limb. If there is inward spread of the abscess, that is, the abscess is going internally towards the internal capsule, then in the opposite direction it occurs. That is, first there is paralysis of the lower limbs, followed by arm and face. And sometimes we also observe convulsions. When the uncinate gyrus is involved, it can cause hallucinations of taste and smell. Parosmias. if uncinate gyrus is involved. And even involuntary smacking movements of lips and tongue is seen. If at all there is any oculomotor palsy or pupillary changes, it means there is transtentorial herniation. Oculomotor nerve is involved or pupillary changes indicate transtentorial herniation. Now, as a homework after this video, I advise all of you all to look at the picture of homunculus. That picture where the entire human body is depicted on the brain as to which organ corresponds to which part in the brain. Please look at that and then go through the clinical features again. It will make you feel better. Okay. Now, this was about cerebral abscess. If it is a cerebellar abscess, how can we localize it? If there is a suboccipital headache with neck rigidity, spontaneous nystagmus on the side of the lesion, ataxia, ipsilateral ataxia, and what are the general cerebellar function tests that are done? Finger nose test, diadochokinesia. These patients cannot do this pronation and supination very rapidly. We call it dysdiadochokinesia. Heel knee test, all of these tests are abnormal if there is a cerebellar abscess. So, you will also have features corresponding to cerebellar abscess. I am assuming you are well versed with this, so I am not writing it down. And then there will be signs and symptoms related to raised intracranial tension also, raised ICT. What are those features? Headache, projectile vomitings. Nausea and projectile vomitings will be there, and then there is lethargy, drowsiness, confusion, stupor, and finally coma. This is progression. Papilledema will of course be there, but it appears after 2 to 3 weeks. When the intracranial tension has persistently been high for about 2 to 3 weeks, then papilledema will occur. If papilledema occurs before 2 to 3 weeks, it means it is a cerebellar abscess. Okay, and the pulse rate is variable and it is usually bradycardia if the CSF pressure is really high, and low grade fever will also be there. These are features of raised intracranial tension. So, if somebody asks you about the clinical features of a brain abscess, you have to talk about it in 2 terms. One is the features of intracranial tension, raised intracranial tension, and second is depending upon the local site of the abscess. Cerebral abscess will have certain group of features and cerebellar abscess will have a certain group of features. So, this is about clinical features. I will move on to the investigations. How do we diagnose? Radiology comes into our aid. First is a skull X-ray. It's useful to see if there is any midline shift. And if the pineal gland gets calcified also, we can see the calcifications in X-ray. If there is any gas in the abscess cavity also, you can see it by X-ray. But usually after these days, skull X-ray is not performed. We directly go to CT scan. Now, the CT will tell you the site of the abscess, size of abscess, if there are any other intracranial complications also, if there is an extradural abscess, subdural abscess, any sigmoid sinus thrombosis, CT will give you the complete information. It will also exactly tell you where the abscess is. You will see something called as a ring sign in CT. Please look at this picture. You can nicely see the ring. How is the ring formed? There is a hypodense area, that is the abscess, and this is surrounded by an area of edema, hyperdense. If at all there is some pathology in the temporal bone, it's better evaluated by CT only than MRI also. Next investigation is MRI. MRI is even superior to CT except for temporal bone, as I just told you. Why is it better? Because the resolution is better and you can see even subtle changes in the brain parenchyma. You can also see the spread of the abscess, where is it going, into the subarachnoid space or into the ventricles. You can localize the abscess very beautifully. And then lumbar puncture. You have to do a lumbar puncture very carefully, or it is better not performed. Broadly, I can tell you lumbar puncture is contraindicated here also, just like in epidural abscess. If at all, if it is done, it should be done very carefully. And if it is done, you will see that the CSF pressure is very high, and because this is an infective condition, there is increase in the protein with normal glucose count is seen. The white cell count is raised, neutrophils are raised, lymphocytes are present depending upon the severity of infection. But the changes that are seen are not as remarkable as the changes that you see in meningitis, because this is a brain abscess. It's not as severe as meningitis. The lumbar puncture, the CSF changes are not as classical as the ones seen in meningitis. Now let us move on to the treatment part. Actually, before doing lumbar puncture, by these non-invasive investigations like CT and MRI itself, you can come into a clear-cut diagnosis. Okay. Alright. So coming to treatment, we have medical treatment. What will you do under medical treatment? A high dose of antibiotics, parenteral antibiotics are given. We combine them to cover both aerobes as well as anaerobes. We can give parenteral chloromycetin, penicillin or third generation cephalosporins. And to cover Bacteroides fragilis, which is an obligate anaerobe, we add metronidazole. If at all Pseudomonas or Proteus are suspected, aminoglycosides are effective. So basically, based on the culture and sensitivity report, the antibiotics are changed. Now we have so many new and effective antibiotics. So neurosurgery is usually being avoided. This is about control of infection. Antibiotics. Then the second problem is the intracranial pressure is raised, and to control that we prescribe dexamethasone. 4 mg dexamethasone IV is given every 6 hours. Or mannitol can also be prescribed. Mannitol will also help in reducing the intracranial tension. If at all there is any active ear discharge, we treat that by suction clearance of the ear. We can also use topical ear drops. Apart from medical treatment, we also have neurosurgical treatment. Now, when such a serious complication has occurred, the case has moved from the ENT doctor to the neurologist, more so to the neurosurgeon. So, they do these life-saving neurosurgical interventions, and this is not the time to manage your middle ear infection. Although the cause is middle ear infection, it is an otogenic brain abscess after all, but still now the time is to treat the brain infection. So, various approaches, either through a burr hole or open incision of abscess, they are all done, and the main goal is to aspirate the pus. Excision of the abscess and aspiration of pus has to be done. If at all the abscess is expanding, then excision of abscess will be done. Otherwise, they just do aspiration of pus, and serial CT scans or MRIs are done so that you can assess the prognosis, if there is any decrease in size or increase in size, and how is the patient responding to the treatment. And once the pus is drained out, that is again sent for culture and sensitivity so that you can change your antibiotic treatment if required. And into the abscess, after aspiration also, we instill antibiotics. This is the main part of treatment. And third comes our otologic treatment. So, any associated disease that has been the main causative factor for the brain abscess, that has to be treated. But only and only after the patient is neurologically stabilized. Only in a stable patient, we take them up for tympanomastoid surgery. So after the abscess is completely managed by the antibiotics or by surgical treatment, then we plan an ear surgery. If it was because of acute otitis media, by now the otitis media will anyhow resolve because of all the high antibiotics that we have been using. If it is chronic otitis media with cholesteatoma, then you require to do a surgery, a mastoidectomy to remove the cholesteatoma. So this is the order of treatment. I hope otogenic brain abscess is clear to all of you. Let me quickly summarize it for you. So what is otogenic brain abscess? It is focal suppurative process of brain parenchyma. Cerebral abscess is more common than cerebellar, and in cerebral also temporal lobe abscesses are usually seen. Please remember that 50% of brain abscesses in adults are otogenic and 25% of brain abscesses in children are otogenic. So what's exactly happening? There is collection of inflammatory exudate and that is surrounded by an area of inflammation. There is bimodal age distribution, pediatric age group and 4th decade of life. And it is more commonly seen in males than females. What is the pathology? First, there is local pachymeningitis, then thrombophlebitis and finally abscess formation. Specific features of cerebellar abscess, there is high mortality and it's usually preceded by lateral sinus thrombophlebitis and the lateral lobe of cerebellum is involved. What are the 4 stages? Stage of invasion, stage of localization, stage of enlargement and stage of rupture. There are the route of spread depends whether it is a cerebral abscess or a cerebellar abscess. Cerebral abscess thrombophlebitis usually occurs. If it is cerebellar, it is direct extension. Causative organisms are both aerobic and anaerobic. We have gram-positive as well as gram-negative bacteria. What are the clinical features? There is deep headache, drowsiness, dizziness and seizures. Clinical features you should learn upon 2 headings. Raised intracranial tension will produce certain clinical features such as headache, projectile vomitings, papilledema and so on. And the site of abscess will produce some localizing features. If it is a cerebellar abscess, you will have nystagmus, ataxia, changes in the heel-knee test, distorted finger-nose test and dysdiadochokinesia, all of them are observed. If it is a cerebral abscess, depending upon the site, there could be nominal aphasia, there could be contralateral motor palsy, there could be homonymous hemianopia, contralateral site, there could be convulsions, hallucinations of taste and smell if the uncinate gyrus is involved, and there could be oculomotor nerve palsy and pupillary changes also. And diagnosis is by CT scan. You will see the ring sign, which is very important. And MRI is also helpful, better resolution and detects more subtle changes. And treatment, number 1 is IV antibiotics, high dose of intravenous antibiotics. Antibiotic is decided based on the causative organism. Neurosurgery to stabilize the patient first, followed by otologic surgery. If it is acute otitis media, you don't need otologic surgery usually. If it is cholesteatoma, then modified radical mastoidectomy is usually performed to resolve the causative factor, that is the middle ear infection. So this is about otogenic brain abscess. Thank you very much.